Hey everybody, I apologize for the rocky start to the semester. I'm going to try to just get some lectures out there to give you an idea of how we'll be doing this and to get us caught up a little bit. You'll notice I haven't posted the quiz for this week. That's intentional because I don't want you bogged down trying to get ahead without lectures. So this is the Chapter 2 lecture. The point of this lecture is pretty much to give an overall idea of readiness for change, who you need to involve, and the type of environment you need in order to institute change. You also need to have an idea of change methods. We will touch on some of these theorists, but we won't go deep into the theory, just know that they're there. A safe environment, you've got to have readiness. You've got to assess all of your stakeholders. If you try to change your discharge time to earlier in the day and you involve nurses without involving physicians or involving the therapy staff, then you're probably not going to be successful. So the hallmark of this chapter is good communication, and that's communication with you and the people that you want to initiate change. You also need to give it some purpose. They've got to know that the change is going to help them. So you need to frame it in a way, if you are switching discharges to earlier, maybe you can highlight that earlier discharge will mean that they don't get admissions at the end of the shift. These are the kind of things that you need to point out to help them wrap their minds around change. When you look at a unit to implement a change on, you've got to look at the environment, the staffing, the morale. If you have a unit with a bunch of new grads, or a unit with high turnover, a unit with a bunch of vacancies, then you're not going to be successful in implementing change because these people are just trying to figure out what it is they're doing on a day-to-day basis. They're not going to be able to do high-level change. And unfortunately, these are the kind of things that we're often faced with, the short staffing and even the 12-hour shifts. You can form your own opinions of that, but there's a lot of research around 8 hours versus 12 hours and the number of errors that happen in the 9th through 12th hour of a shift. So something to be aware of. The quality and safety education and nursing competencies. I apologize, I'm in the airport.
If you are booked on the Delta flight Detroit to Nashville.
These are the kind of competencies that you need, and we throw around the idea of competencies and sign off for competencies so that they're there when the Joint Commission comes around. But you really need to be aware of this kind of stuff because these are the things that the staff needs to understand in order to implement change. So this is just a starting point to go through your staff and say, what do they understand? Who is in what spot? Maybe your charge nurses are ready to implement change, but your new grads are going to need a lot more support and help. And this kind of goes back to the competency. SBAR is something we hear all the time. We form reports around SBAR. We talk about using SBAR for safety. And it's the kind of thing like competencies that we say, oh yeah, people know about SBAR, they know how to do it. But you really need to dig in and find out because especially for your new grads, especially for some of your physicians, do they really understand how to describe all the parts of the SBAR? And we need to not take SBAR for granted. A new grad that calls a doc and says my patient's blood pressure is low is going to get frustrated because 3 o'clock in the morning the doc's going to yell at them, they're going to get upset. But if they call a doc who and they say, I've got a 75-year-old patient that just had abdominal surgery, he's been bleeding a little bit, and now his blood pressure's 60 and his heart rate's 120. I think it's because of blood loss. Can we get an H&H type and cross, et cetera, et cetera? Then, they're going to develop a pattern. They're going to use that pattern every time they call a physician, and B, they're going to avoid that frustration. So don't take anything for granted and some of these things that we see as check boxes to have to talk about at staff meetings may be useful. With quality monitoring, we have to remember that our role is different from the staff role. The book talks about rapid cycle change versus continuous quality improvement. The people on the front lines are the ones doing rapid cycle change. You know, I tried this way of starting my patient rounds today, and it really worked well. And then it's our job to say, would this work for the unit? Would this work for the rest of the hospital? So we all have different roles, but you also need to develop, again, back to the communication, got to develop that open line so that people can come to you and say, I've tried this and it works. What do you think of trying to push it out further? The COPA model is outlined in the book. Again, I want you to use this to assess readiness for change. When you're doing your change project, you need to be aware of these points, be aware of how they occur on the units you're looking at implementing change. Again, communication skills are the biggest thing. I think about a physician that I heard about just last week from a patient. Walked into the patient's room and said, I'm going to admit you, and by the way, if your heart stops, do you want me to restart it? And this was from the patient's family member, but the patient had a DNR at home on the refrigerator. But if I ask you, if your heart stops, do you want me to restart it? The natural answer is going to be yes. And that's exactly what happened here. This patient who had talked about it, had told her power of attorney about it, had the DNR on the fridge, said, yes, doctor, please restart my heart. So the physician had gone in and had done his job because he needed an answer, DNR or full code, but he hadn't done it in a way that involved the patient and got the outcome that he really wanted. I think of another story, our CEO, they talk about doing interviews with him and how an interview with the CEO can seem like just a casual conversation over a cup of coffee, but then when you're done talking to him, you realize that he's completely interviewed you and knows you inside and out. And that's the kind of thing that SBAR and other scripting does. I'm not a fan of scripting, but if you can take a script and practice it, make it your own to the point that it feels comfortable to you, then you've achieved something. If that physician was coached, maybe he was put in front of a camera and recorded an interaction with a patient, we can do the same thing with nurses. Then he can say, you understand that we can keep you alive with unnecessary means. We want to do things for you, but not do things to you that won't work. What do you think? That's the kind of thing that can develop into a meaningful conversation that still feels comfortable, feels natural, but the physician has gotten the information he wants. So just glance through all of those competencies, make sure you're aware of them, make sure you're aware of how those things are being performed. You'll see as you go through the competencies that they get more and more advanced, so you're going to need a unit that's further and further along before you start integrating knowledge and family and environment. Be aware of the staffing. Be aware of the staffing implications. If you are in an ICU and you have 2 patients for every nurse, then you may think, okay, I'm staffed fine. The only problem comes when you realize that these patients are going out to the floor early, they're going out to the floor sicker, and a nurse may come in and have 2 patients, and by the end of the shift have 2 completely different patients, have done another set of admission assessments. It's all really time consuming, so you have to look at that, and I encourage you to collect data, especially if you're short staffed. How many shifts were you able to staff to 100% of your matrix? How many shifts did the nurses have to take more patients than you originally planned for? We all budget for hours per patient day, but very rarely do we actually work at those hours per patient day. So those are the kind of things that in California they're mandating ratios, but we've still got the ability to use clinical judgment to look at acuity and to make a case for whether or not we have enough staff. Again, talking about the simulation, I've had a lot of good luck with videoing interaction, with letting people do SBAR or ADIT or any of the other techniques, hourly rounding. They see themselves do it on camera, and then they realize that maybe they're not coming across as wanting to help. Maybe they're coming across as, I need to get a job done. Do you need to go to the bathroom? No, good, thanks. So that's the kind of thing that some kind of simulation can help. Again, with the rapid cycle change done at the bedside. Team steps. This is a model for that communication, for identifying issues. You can look at the website. I've got the link at the end. People become certified in steps, and it's really basic, but it's really really meaningful. There's an ED video on the STEPS website that shows a nurse walking out, talking to the physician, saying, hey, I think this patient's having a heart attack. The physician brushes them off. The nurse just stays at it until the doc comes in. And then it's got a good example of the ED physician calling a cardiologist, giving an SBAR handoff. And these are the kind of things that you have to realize if you've got a medical staff that won't buy in to SBAR, if you've got a nursing staff that is too young and insecure to go up to a doctor and say, get off the phone, I've got a sick patient, I need you here now. Those are the kind of things that you have to be aware of when you're implementing change. The all-at-once concept is that holistic, top-of-the-stack nurse that integrates not just what's going on in front of them, but also looks at family, looks at the patient's environment. Where are they going home to? What are they going to do when they get home? This is what we want all of our nurses to achieve, but it's something that we have to guide them through. They're not going to be there when they walk out of school. Here are those stakeholder points of view. You've got to remember to look at your change project from every direction. Consider the impact on each person. Consider those ripple effects that are going to affect all the other people, and realize that different people are going to have different priorities. So you've got to address your change from their perspective. We don't want to walk in and say, here's what we're changing, go to it, make it happen. We've got to have, again, interdisciplinary communication. You need feedback. You need to get some readiness to change. The readiness to change is going to be different through your workforce. You've got your early adopters, and then you've got your laggards that are not going to accept it until they've watched it happen. So you need to find out who they are and make sure you get those early adopters on board quick. Make sure you involve everybody. Is it going to affect the doc? Is it going to affect food service? Is it going to affect the secretary? Make sure you know who's going to be impacted by the change and talk to them. Lewin's force field analysis just talks about the forces and how they're going to equalize themselves. And the people that don't want change, maybe they'll win. The people that do want change, maybe they'll win, but either way, it's going to settle out in the middle, so you need those early adopters. All of these other change theories, if you look at it, you kind of see a progression through practice. They start doing the most basic things, and then they go on through and they get more advanced to the point that they're looking for solutions, trying to make change for the better. And this is a good grid to kind of assess readiness for change. Here are the resources that I talked about. IHI Trigger Tool, I'll talk about some more later. But just take a look at this. These are some things that will help you with your change project, and let me know if you have any questions or concerns. I'll be glad to help. That's it for Chapter 2.